So in the year 2000, when people began to get away from CO2 in large degree because of some of the complications and pushback, I found the erbium. I had been told the erbium was superficial, and quite honestly, I saw a lady came in who had been mistreated with the erbium, but she had a deep injury. I ordered my erbium the next day because I knew if it was superficial and it could also go deep, I could find a place in a sweet spot there. And I have, and for 14 years, I've used the erbium. I sold my CO2s shortly after that, and I've never regretted it. I believe that what we thought we were getting back in '95 with the coherent ultrapulse, really we got with the erbium, because we thought we were getting very little heat generated. The erbium does that. If you look at what we thought was an advantage, you've got an ablation threshold with CO2 of 5 joules per centimeter square, so we could actually ablate tissue for the first time. But how much better the erbium at an ablation threshold of 1 joule per centimeter square. So now you got 11, 13 times the affinity for water, so I can ablate. You know, a study that really tells it all as far as I'm concerned is there were 2 studies that came back in the mid-90s, one from Boyd Burkhart in plastic surgery and one from Dick Fitzpatrick. Almost came out at the same time, simultaneously, the same study, unbeknownst to each other. 10 passes with the CO2 laser, wiping between each pass and seeing how deep you could go. Both articles said exactly the same thing. After 4 passes, you could go no deeper, because if you're only at 5 joules per centimeter square, the char buildup is so much that you can't get through it. So the only way that you can go deeper with the CO2 is to sit there and pulse stack. When you pulse stack, you get heat and you get hypopigmentation. So every time I worked with the CO2 around acne pit scarrings, deeper wrinkles, having to build up that heat, that's where you get the hypopigmentation. With the erbium, at 1 joule per centimeter square, it sees the water through a smaller eschar, only 5 to 20 microns, as opposed to the 70 to 120 you're getting with the CO2. So it sees right through that, and you can just keep going, and you don't even really have to wipe anything off. So for me, I feel what I have is the most amazing dermabrader in the world, a laser dermabrader, and it's not occluding the tissue. With a dermabrasion, the wheel is actually obliterating what you're seeing. But with the laser, with the erbium laser, you can treat that and see the endpoint as it dermabrades. It's just phenomenal. So my technique is to go in and get down to around 300 microns on deep wrinkles around the mouth, and then come in with my 30 micron per pop dermabrader that I can, laser brader if you will, and see exactly those wrinkles go away. And when I can either see the endpoint that I stop, or I can see the wrinkle go away. So for me, it's an exact endpoint. You contrast that to chemical peels. Well, chemical peels is an indirect. It's what is the color change in the skin. It's not the wrinkle itself. It's not the bleeding endpoint. You don't know how deep that peel is going. People can be good at it, but it's still an indirect endpoint. CO2, indirect endpoint. It's the color, it's the chamois, it's the yellow, right? With erbium, it's the endpoint. It's a direct endpoint. The wrinkle's gone. You're in the mid-reticular dermis, and that's why I love the erbium, and that's why it's supplanted that. So I can go deep. I can go superficial at 10 microns and do a little mini peel if that's your bent, or you can go deeply and get some of the deepest wrinkles on the planet. There's no device better.
So tell me a little bit about how you use the erbium in your OR, say when you're doing a facelift.
Okay. All right, so the reason I like the erbium when I do it with a facelift, it has less heat transmitted to the tissue. I can dial that in with the Sciton device. I can tune it in as a tunable erbium laser. I can put more heat or less. My bias is to tend to use less heat, especially when I'm using it with a facelift. I use no heat because I've elevated my flaps. There's a little bit less blood supply. But the blood supply is poorer the further away you get from the blood supply. So if the central face is where the blood supply is, then as you go further toward the ear, the blood supply is more poor. All right, so I wouldn't recommend everyone that does this unless they do it just like I do it, because I don't have experience with other techniques. But my technique is I do a high SMAS, deep plane lift, better blood supply. Then what I do is in the central third of the face, between the lateral canthus end, I treat it just like I'd normally treat anything else. I can go 300 microns on the lip with that dermabrasion or laser abrasion technique with the 30 micron per pop single pulse technique that I've talked about. It's on webinars, it's written, you can review that. But I don't change that, whether I was doing a facelift or not. The key though is from the lateral canthus out, you have to tone it down. I go about 150 microns for the 2 centimeters just lateral to the lateral canthus, then 100 microns, and then I'll always leave a centimeter around the ear. This has been proven over trial and error. When I went to the ear, I never had significant loss, but I would have occasional trouble with secondary healing and a little bit slow to heal. Now that I've left that alone, the centimeter in front of the ear, and then I just gradually go from 100 for a centimeter, 150 for 2 centimeters, then I'm at the lateral canthus, and inside of that I can go ahead and treat aggressively, which are where most of the wrinkles are. So I found that to be very effective, and patients just don't want 2 procedures. So I've come up with a technique, in my opinion, that works for me and my patients, and I've never had a significant scar doing that. Now, I will be honest with you, I've broken my own rule. So follow my protocol, because I had a patient of mine that had horrible wrinkles, probably the worst I've ever seen. So I thought she needed a little more aggressive treatment on the cheek, and I talked to her about it, told her didn't think it would be a problem, but it might be. And I went 300 microns on out over the cheek, and I lost skin. So I'm just telling you, as just being honest, and for the people that might be listening to this, do not push this protocol. Do it exactly like I said. You might have a problem, but so far I haven't had any, and I've done hundreds. But if you break that protocol, you might have a problem, because I did. In the one case that I broke it, I paid the price.
So let's talk for a minute about the results. What kind of results are you getting? How satisfied are the patients once they get through the healing?
Okay, so the results that I'm getting, I'd say the proof's in the pudding. We presented back even in 2005 when I was relatively early on in the process. I had 5 years experience, but not 14 like I have now. We presented 25 consecutive patients, not cherry-picked. So they're just every one in a row. And all of those patients had 90 to 95% improvement in their perioral rhytids, which is the best I've ever seen. We're in the process of writing up our combination procedures, but I just would say the proof's in the pudding. Look at the before and after pictures, and I just think they're the best I've ever seen. I do think that Greg Heder and some people that are fabulous at chemical peels show great results. But Greg himself told me that those results come at a cost with a phenol peel of hypopigmentation. For the kind of results I'm getting, if you get that with a phenol or a croton oil peel, you're going to get almost 100% incidence of hypopigmentation. And my incidence of that is very low. I'd say less than 5%, and when I get it, it's mild. So I love my results, the patients love my results. I just think that as plastic surgeons, we sometimes miss the boat, because if a patient comes in and she's 65 and we can take them back to 45 or 50-year-old contour, but that skin is not addressed and it still looks 65 or 70, people might say that's a bad facelift, when in fact it's a great facelift. It's just not a perfect look. It's not a natural look, because the skin is 70, the contour is 45, and it doesn't match. So when you can treat all the components of aging, not only the gravitational, the dynamic lines, and then you treat the skin to match that, then you have a patient where she looks more natural. So more is actually better. And, or what you'd say more is less, because it just looks more natural. It all comes together. We age as a unit, and volume, skin, gravity, and dynamic. If you treat all of those things, you actually look less operated than more operated.
Awesome.
Perfect.
That's great.